come back. Oh, that's a lie. I tried to close the rooms. You can't close them faster than a minute. Sorry, y'all. I didn't realize I couldn't do that. Let's see. Got most people coming back. Okay, let's see. 25 seconds and we'll get everyone else back from the breakout rooms. Okay. Can I make you ask you to share the problem representation? Share the problem representation, Jake? Okay, cool. Okay, so I think we've got most folks, almost everyone back. Come, a few more seconds. Okay, so welcome back from your breakout groups. So I'd like to have one of the fantastic interns here at Denver Health share what he came up with for our problem representation. Go ahead, Jake.
All right. This is a young male with a history of IV drug use who presents with acute onset back pain and fever concerning for the distributive shock. Awesome.
Would you guys agree with that? Any additions? You can throw them into the chat. I think it's probably the easiest way to have that. Oh, sorry, I just saw the go back to labs. Okay. Excellent. And one question that came up in our group was the lactate in terms of if it's really helpful for diagnosis of shock or not. I think it's just another piece of information in the clinical picture as you're looking at this patient. And it's important anytime you do have that elevated lactate to then trend it moving forward and see if it's responding appropriately to treatment. So we've got a good problem representation. Let's see about this distributive shock. So we agree that in this case, it sounds like it's sepsis. He really seems like he's got an infection somewhere. And I'll have, how about, I think I saw Team D from the VA up there. So I'll ask you guys maybe to throw into the chat. What other causes did you guys come up with for distributive shock? Oops, we're doing pulling up the chat again. Sorry, I can't do it. Thanks. Neurogenic, awesome. Perfect. So we've got that. We've got anaphylaxis, neurogenic, adrenal insufficiency, liver failure, inflammation, especially things like pancreatitis, as well as drugs. This is anything where you have increased cardiac output, your heart rate is high, but you're not getting enough tissue perfusion at the end, kind of due to vasoplegia or inappropriate vascular response. So we've correctly identified distributive shock, but we're not done yet. Mr. R makes it up to his room from the ED and the nurse calls. She says he did get some IV fluids ordered. It was a total of 30 cc's, not 300. Not trying to create cardiogenic, 30 cc's per kg. And then he got another 1.5 liters after the ED saw those initial lactate and labs. Those are all done now, but his blood pressure is still 92/48. So a hair better than when you saw him before. And his heart rate's still 108, also just a touch better. So the nurse also mentions they don't know the patient, but he seems a little confused. And if you remember from before, he was alert and oriented times 2 to 3 in the ED. So what do we want to do now? You guys might start noticing a theme. We're going to go to the bedside. I think, again, the key here is anytime you get a concerning call, please go see the patient unless you just saw them and you know what's going on and you can offer a realistic response. I like where you're thinking, Team A. Okay, so on repeat evaluation, his arms and legs are still nice and warm. But he's trying to get out of bed. He's mumbling something you can't understand. And as opposed to before, he really isn't answering your questions. So what do you do? I'm going to try and start my other poll. We'll see if this works. Okay, 2 of my polls came up. We'll see what this one works. Yeah, okay. So another poll. Tell me, what do you guys want to do? We'll give you about a minute to answer. We'll let Jake and the group in the corner throw an answer in. Okay. Oh, there seems to be a pretty solid consensus here. So I'm just going to give it 10 more seconds. So I'm going to share the results. I love it. You guys are all on the same page. We are going to do antibiotics and pressors. Just to highlight here, we're not talking about treatment of septic shock, so we're going to skim over antibiotics and just agree that those are an important addition to his care plan. And I think the other thing I'd like to highlight here is we're starting IV antibiotics. That's something I think all of us, everyone probably feels comfortable with doing on their own. But when you're talking about starting a vasopressor, that's the point at which, even if you can't necessarily get someone immediately, you should definitely be making your senior, your attending aware. Because like Corey mentioned yesterday in his lecture, this is going to be a transfer to the ICU if they're not already there. It's going to mean lines for central access and just kind of a considerable change in patient status that we really, not because you're making the wrong decision, but just because of that change in status, it's important that people know about it. So you've decided we're going to start a pressor, giving antibiotics, and we let your attending and your senior know. This is the part where I don't talk about Q-SOFA and sepsis, because Danny's going to talk about that, just highlighting that it does exist. So instead, we're going to talk about pressors and what pressor you want to choose. Pressors in and of themselves can be a talk, so we're not going to draw this discussion out too much. I think the thing to highlight here are you really have 4 choices: norepinephrine, phenylephrine, vasopressin, and epinephrine. All of them are generally appropriate for distributive shock, like we've talked about. The differences tend to be the degree to which, or just receptor selectivity and the degree to which they bind to different receptors. And that affects if they're going to impact heart rate as well as blood pressure, and where that balance will be. Again, for the purpose of moving on to our other cases, I'm just gonna say, ask in the chat quick, what pressor do you guys want to start? Or unmute yourself, like, yes, I love it, Levophed. Levophed is really the workhorse pressor. When in doubt, I think you're rarely going to be wrong to start norepi for someone who's in shock. Just, again, reevaluate, and if they're not responding the way you expect, think about maybe if it could have been cardiogenic or if there was another better option. So, again, we're going to move on. The first 2 cases are the bulk of our time, so we're still moving in the right direction. But we'll say you start him on norepi, he moves to the unit, gets a central line, and starts to recover. So you appropriately managed your first patient in shock. Nice job. So time for case number 2. You're feeling good. You got a little bit of a late lunch after that admission. And now the nurse is calling you about Miss S. This is a patient you picked up from overnight who's hypotensive, and the nurse just says hypotensive with a blood pressure 75/43. She wasn't your primary this morning, so you don't really remember everything about her. What do you want to do next? And I apologize, my other poll has not, didn't make it into Zoom. So instead, we can answer exactly. Okay, so the options are repeat vital signs, review the chart quick, see and evaluate the patient, or all of the above. Looks like everyone's in agreement. We're going to do all of it. I think that sounds like a really good idea. So you're going to the bedside, noticing a theme. while you ask the nurse while you're on the phone to repeat a set of vital signs and take a look at her chart in haiku while you wait for the elevator. While you're in the chart, and you do have a decent amount of time to wait because there's only 2 elevators ever, you refresh your memory that she's a 75-year-old woman who came in from a sniff due to confusion. In the ED, she was found to have a urinary tract infection, started on ceftriaxone, and resuscitated with about 2 liters of normal saline. And this is a rough depiction of what her picture in EPIC looks like. You also realize looking through that she's never been seen in this hospital before, so you don't have any other records, and you don't know what her home medications are. This morning on rounds, when you see her picture, you remember that she was sleeping, but your co-intern mentioned that her vital signs were normal and her white blood cells had improved from admission this morning. You're still waiting on those outpatient records as far as you know. So we get to the bedside. Vital signs, she's still afebrile, heart rate in the 80s, blood pressure is about what the nurse told you. She's satting in the low 90s on 3 liters. Not sure if she had a baseline oxygen requirement or not. You examine her and notice that her JVP appears to be elevated. You think at least to the angle of the mandible when she's sitting up at 90 degrees in bed. There are definitely some bivascular crackles going on. And she's got cool shins and forearms with 2+ edema at least. She's alert and oriented only to herself. And in comparison to her chart picture, she looks a little fluffy. So what imaging would you guys pull up? And you can throw it into the chat, unmute yourself. Anyone in the room can yell it out. Are there imaging modalities that might be helpful here? Chest x-ray, awesome. And yes, I love it. The thing that's even faster, cardiology for the first answer, ultrasound. So point of care ultrasound as well as chest x-ray. So just to offer a really quick review, because this is not the point of our lecture here, but the normal lung on a linear probe is going to have A lines. Those are reflections of the pleural lines at normal intervals. And you don't really see much on a normal lung ultrasound because it's pretty much air. So you grab the ultrasound, you actually had some foresight and grabbed it on your way into the room, throw it on her chest, and you see this. Do you guys remember what this finding is called? Yell it out. Yes, I got it in the room. So B lines. So the cause of this is most often pulmonary edema, increased interstitial fluid. I want to highlight here that with a skilled operator, studies have shown that the estimated sensitivity and specificity for B lines on ultrasound is greater than 95%. So if you see this, you're worried about pulmonary edema, that tells you with a pretty high degree of certainty that that's what's going on. For the sake of completeness, we're going to say that as you finish the point of care ultrasound, your senior who'd been chart stocking have thrown in a chest x-ray. The x-ray tech comes in and the chest x-ray looks like this. So not good. Just to highlight here, the major difference between chest x-ray and ultrasound for pulmonary edema is sensitivity. Chest x-ray is only about 30–35% sensitive. It is highly specific though, so over 90%. So that means if you don't see pulmonary edema on chest x-ray, it still might be there. And if you trust your ultrasound, that's most likely a better modality to evaluate with when it's available. So time for the next breakout. The 2 tasks for this breakout room, I'm gonna give you another 3 to 4 minutes here, are as you leave the room, the charge nurse hands you a stack, at least 300 pages of records and asks what you want to do. As you carry that back to your room, think about what 3 pieces of information you are searching those records for. And then again, I'd like you to think about what type of shock this is and what other causes there are. Oops, we're gonna breakout. Okay, ready, go. Okay. Oh, 5 seconds. Everyone will be back. Okay. So this time, I'm going to go ahead and call on maybe we'll say if any of the the VA team or the cardiology team is able to either unmute yourself or throw into the chat what pieces from the records you're looking for specifically. It's obnoxious, yeah. Okay. Okay, oh, I see. So it looks like echo. Awesome. Any other things that people are looking for from the chart? Oh, no micro video. More recent echo, hospitalizations, home meds. Excellent. So you skim this chart and you see that the bulk of the records are from her cardiologist. She sees him all of the time. She has a history of ischemic cardiomyopathy with about at least 3 stents placed 5 years ago and maybe some other stents in the past. In addition, her last echo that you are able to find is from about a year ago with an EF of 36%. You also are able to find at least a medium current list of home meds. It looks like she should be on metoprolol, lisinopril, and some diuretics. Other things that came up in our room that you might want to look for, I thought were great, were things like code status, contacts, and other past recent hospitalizations. Again, I think there's not only 3 right answers to this question, but you definitely want to have in mind, especially when you're approaching the EMR that can have so much information or a large quantity of paper records, you want to have in mind what you're looking for, not just kind of wandering aimlessly. So, and I think we all kind of agree, this is cardiogenic shock. The other causes we talked about, there's MI, valvular failure, arrhythmia, myocarditis, and end-stage cardiomyopathy. I did highlight decompensated heart failure here because I think it's probably the most common cardiogenic shock. And I also think that it tends to be something that we see that is iatrogenic. Not often do people necessarily come into the hospital with it, but it's fairly frequent that we might give it to a patient. So remember that even if they didn't come in with a problem, they can have a new problem. So how do we evaluate for cardiogenic shock? Do you guys have kind of things that you're looking for in your mind? Go ahead and shout it out. EKG, perfect. So this is a little read my mind, but we want to get a physical exam and kind of decide anyone who has this history of heart failure, where they are in the warm, wet, cold, dry spectrum. So in a perfect world, everyone with heart failure would always be warm and dry with lovely compensated heart failure. Unfortunately, they can be warm and wet. And then and by wet we mean generally edema. Once they get cool or wet, or even more concerning, cool and dry, we're worried about cardiogenic shock. So from this woman, if you remember from her exam, her extremities were cool and had edema. So pretty consistent with this picture of cardiogenic shock. Not to dwell too long here to make sure we try and get through the last couple of cases. But again, this is the point where I would highlight asking your senior, or maybe even considering consulting cardiology is appropriate. Really, generally shock isn't a problem that any one provider is going to manage alone. So you reach out to your senior who already knew about her because she threw the chest x-ray in, and you talk with cardiology. Cardiology reminds you that the blood pressure is low because it's a product of cardiac output and systemic vascular resistance, and that cardiac output is related to heart rate and systemic vascular resistance. We have some other talks on cardiology, so we're not going to dwell into this too far, but I do want to highlight that the goals here when you're treating cardiogenic shock are to optimize preload, improve contractility, and optimize afterload. So preload tends to be diuresis. We know that that's already probably going to be a good, important therapy for her because she's supposed to be on diuretics as an outpatient. And then improving contractility is where we get into inotropes, which is where we'll talk a bit, as well as optimizing afterload, and you might want to consider a vasopressor or vasodilator. So you talk with cardiology, they decide that an inotrope is probably what, in addition to diuresis, is what they want to do for her. And so we're going to talk just very briefly about dobutamine. It is the inotrope we use for cardiogenic shock. It has very strong beta activity and it will improve cardiac output. So just kind of, if you think about thinking about cardiac shock, reduced ejection fraction, reduced cardiac output, think about dobutamine. Okay, so we've made it through 2 cases. This has been a long day. You've already had 2 patients in shock, but it's not over yet. These next 2 cases are quicker. They're more highlighting, again, common ways that these types of shock present. You've got another patient, saw her this morning. This is a 66-year-old woman who came in with electrolyte imbalances after having a lot of GI losses for chemotherapy. She has, pretty sure, breast cancer. Electrolytes have normalized after 3 days in the hospital. She's tolerating PO and is going to discharge this afternoon. You go into her chart to sign the discharge order, and you notice her heart rate has jumped up to the 130s, whereas it had been in the low 70s. What now? I think you guys know the answer. Go see her, exactly. So you go to the bedside. When you go to see her in the room, her heart rate is tacking away 130s, blood pressure lower than you'd like to see it, 100 over 70s. She looks anxious, uncomfortable, but her initial exam doesn't really have any other localizing findings. You decide that since it appears to be mostly heart related, get an EKG. This is what it shows. Someone want to throw in the chat or shout out, what do you see? It's not a trick question. You're going to be right. Yes, sinus tachycardia, exactly. We're gonna give you, we'll say 2 minutes in the exam room or in the breakout rooms here. I want you guys to come up with the exam maneuver you think would be most helpful, the additional study you'd like to order and why, and then talk about what type of shock this is. Come on, why does it do this? Gave you the answer. I was trying not to do that. That's okay. Okay, so breakout rooms, 2 minutes. Okay. Thing would be CT. Okay, so we're back. Oops, I think we're, so the exam maneuver, rather than making you guess, that I wanted to talk about is Pulsus Paradoxus. With the thought that this woman may have a PE, or seems to have potentially some obstructive physiology. So the Pulsus Paradoxus is where the systolic blood pressure decreases. You can see that's the pulse pressure tracing above the respiration line. And the systolic blood pressure decreases by at least 10 points with inspiration. This is due to decreased pulmonary venous return and increased right-sided pressures, leading to decreased cardiac output. So again, just to highlight here, if you see this, or if you perform the maneuver and perform a blood pressure and watch the systolic blood pressure with inspiration and expiration and suspect Pulsus Paradoxus to be present, it has a sensitivity of 98% and a specificity of 83% for tamponade physiology. So then other studies, again, there's not a right answer here. I think probably one of the most common ones is going to be a CTPE. This one has the lovely arrow sign showing where the contrast is not making it into the pulmonary arteries. Other very reasonable studies that we discussed are things like lower extremity Doppler, as well as a echo or bedside echo, looking for signs of right heart strain. So making sure we get through this. She has obstructive shock. Essentially, her cardiac output is not what it should be due to mechanical pressures on the right side of the heart. Things that can cause this: pulmonary embolism, again, probably the most common presentation of this. Also tension pneumothorax, cardiac tamponade, and constrictive pericarditis. So then briefly to touch on, when in a pulmonary embolism do you call for help? I think this is a moving target. I think sometimes people can come into the ED, be found to have a pulmonary embolism kind of incidentally on CTPE, but hemodynamically stable, started on anticoagulants and go home. But at this point, when the patient's having like hemodynamic compromise, very important to at least contact your senior, and again, your attending, let them know, and consider talking with pulmonary or the pulmonary embolism team, depending on the hospital you're at. Okay, last case, we've got 10 minutes. I think we'll get through this. So you get sign out. Now you're, a few days later, you're coming in on for your cross cover shift. You get sign out for a 55-year-old gentleman. You hear he's got a past medical history of HIV cirrhosis, alcohol abuse, admitted late this afternoon for altered mental status. They're pretty sure it's hepatic encephalopathy. He got a couple doses of lactulose, but hasn't had any bowel movements yet. Your night's smooth sailing, nice and calm. You're about to sit down to dinner when you get a page. So you're about to eat dinner and you hear he's finally had his bowel movement, maybe a little less confused, but it looks pretty dark and tarry. What are we gonna do? Awesome. See the patient, think about some labs. I love it. So you go to the bedside, and as you're going there, based on what you know about this patient, what type of shock are you most worried about? Hypovolemic. Excellent. So I just wanted to make sure we got through this and highlighted this. Hypovolemic shock, kind of reiterating from Corey's case yesterday, most commonly we see from a GI bleed. That can be due to variceal, hemorrhage, or any place in the GI tract. Also dehydration, people coming in with lots of losses, as well as third spacing, especially in the setting of things like pancreatitis or cirrhosis. So I know the last cases were kind of a little more brief and rushed, but I want to make sure we got through all of them. We've got a few minutes. If there's any questions, concerns, other things that you guys wanted to highlight or ask, you can go ahead and throw it into the chat. I'm going to stop screen sharing there.
I have a question about Pulsus Paradoxus, because like I've heard about it so many times, but I feel like it's a unicorn. Like I've never actually seen anyone do it, and so like, but it has like high sensitivity and specificity. So like, in practice, how is it performed?
Excellent question. So if anyone on Zoom couldn't hear that, it was how do you actually perform Pulsus Paradoxus? Which I think I agree. I think it's talked about all the time, and I don't think it's done nearly as much as it's talked about. The first way, I'm going to go back to screen share, and I'll go back to the image of Pulsus Paradoxus, because I think that kind of illustrates probably the more common way that it can be. People have the suspicion of it.
It just seems weird to be like someone who's cardiac and potentially like having some respiratory issues. Be like, okay, now like inspire and like hold it, you know?
Yeah, and so it can feel odd. I think the patients can usually tolerate it pretty well. One way that it can be done without necessarily having them hold their breath or anything like that is if they happen to have an A-line. And so you can see the blood pressure tracing go along with their respiratory rate. That's in the perfect world where they're somehow in the ICU when this happens. Or if their blood pressure cuff is on and you can see it on the monitor. More often you can get a manual cuff and you do it once, having them breathe out. And then like you said, you can time it so you get the cuff ready and then have them inspire so they're not necessarily holding their breath in. It's worth practicing. It's especially if you have a patient that you suspect is going to have a positive Pulsus Paradoxus. Yeah. Yeah. Oh, looks like maybe something from the, oh, perfect. And Sneha. There you go. Yeah. So this is like the written out description of, does that make sense? Okay, yeah. So EKG from a few slides back. This is just kind of like a stock image that was supposed to be sinus tachycardia. The other thing is the wandering baseline is just showing that she's breathing pretty quick. Awesome. Well, great job, guys. Thanks for your participation. Any other questions or concerns, always let us know. And we are recording these, so hopefully people who are on nights, things like that, can get it. Yeah, absolutely. Nice job, guys. Ben and I.